So thank you everyone for joining. Just as a friendly reminder, we're going to be doing these the second Tuesday of every month at around 6 p.m. And so please feel free to share this with your various networks, the people that you know, anybody that might find value from these. The website that we generally share will always kind of work, and you can always direct people there to register. It'll always have the latest update stuff there. So your help in sort of spreading the word would be appreciated. But with that, Dr. Gandhi, I'll let you take the floor.
Well, thanks guys for logging on. It's a small group tonight. I think as the weather gets better, the group's going to get smaller and as school gets out, I think. But nonetheless, I'm happy to answer any off the cuff questions you have, or we can make this just a friendly conversation. I have a list of questions from a bunch of people, most of whom aren't on the call, but I'll go through a bunch of them. But I was going to start out imposing on someone. Heather, I don't know who you are, but you had a nice comment that you wanted to help other parents because you're an adult with congenital heart disease. So if you want to just tell people your story, I think that would be good. Just give everybody a couple liner on your story.
The room here, one moment. Okay, sorry. Okay, so I am 48, turning 49 in about 2 months. I was born, didn't quite know exactly what happened because, again, technology back then was not as good as it is now. So at the age of 5, I had to have open heart surgery. I had too much muscle tissue around the walls of the left side of the heart. So the doctor had called it a left ventricular myectomy. But in some ways, I did have some sort of pulmonary stenosis. So we corrected that through the aorta. Then 8 months later, I had to have another surgery, which was done through the actual heart muscle itself. And that was a 50-50 chance of survival at the time, which was about 1981. Lived life awesomely up until about 2018, where I was diagnosed to have a pacemaker because the top part of my heart and the bottom part of my heart were not conversing. And so I would it would feel like an elephant sitting on my chest, and I would have sharp pains in between my shoulder blades, which I did not have a heart attack. So I, always went through the list. And now 5 years later, I still have the pacemaker. I'm doing good. We do notice that I have some sort of AFib going on. Ended up having a cardioversion in October, which worked well for 2 weeks. And now it didn't work. So now we're just playing around with my heart medication to make sure that the AFib or my heart would go into a normal sinus rhythm. And then if it doesn't, then we may have to look at I can't remember what it's called.
Called an ablation.
An ablation, yeah.
Well, good. So thanks for sharing.
Right now I'm good.
Overall, you're doing okay. Well, thanks for sharing. I think that
okay. Yeah,
helps some parents whose kids are still in the early stages of this. And then I was going to ask Juanita. Juanita, you said your son, I guess, is an adult now who was born with hypoplastic left heart syndrome and had a heart transplant?
Yes, so he was born in 1991, and he had the Norwood, the Glen, the Fontan, and then developed protein-losing enteropathy after the Fontan. So he I guess then they opened his fenestration at that point, saying, like, our doc here, like I'm in Saskatoon, said he had never done anything like that before, but it happened to work well for my son. But then in opening that fenestration, his oxygen saturation level was usually around 74, 75%. So after living with that, I think he was about 15 years old. Yeah, I think it was 14, 15. Then he developed polycythemia and then was at more of a risk of stroke. So they're like, okay, we have to close the fenestration. So went through that process. It wasn't closed totally, but that was the pinkest I'd seen him for, numerous years. And then I don't know exactly what year he developed protein losing enteropathy again. And then probably roughly 2018, he started getting quite sick. And then I'm trying to think, because they assessed him in 2015. So it must have been before that he had protein losing enteropathy come back again and said he wasn't eligible for a heart transplant. Because at that point they said he had too many antibodies. So at that point, like I guess we just assumed or thought heart transplant wouldn't be an option for him. And then went into heart failure again, some more, like they tried managing him with meds. He did go on the budesonide, tried different things. And then that started about 2018 again. And then 2020, they said that they would list him. And even then they said he was 100% sensitized. So they said a less than 1% chance of finding a heart. But 7 months later, he got the call and had a transplant and is still doing well today. So I don't know, it's amazing just to me to think about it. So.
Yeah, that's a good story. So he was like almost 30 when he got his transplant.
Yeah, he'll be 30, 91. He'll be 33 this year. So he was 29 when he got his heart.
Yeah, that's a really good story. 1991, the Norwood operation, the mortality for the Norwood operation was 60%,
yeah,
70%.
Yeah.
So the fact that he got through all three of those in the early 90s, it was really only sort of in the mid to late 90s where surgeons started to figure it out a little bit more and mortality started to drop a little bit. So did he have his heart transplant where, in Toronto or Edmonton or?
Edmonton, yeah.
Yeah.
So his surgeries, like when he was born, we had to go to Toronto because that was the place where it had the most expertise. And then in 2010, I think it was, when Dr. Rebecca moved from Toronto to Edmonton and they started developing their program there more, then we started going to Edmonton and had surgeries there. So like Derek's transplant would have been his 5th open heart surgery, 5th or 6th anyway. So.
Well, I'm glad he's still doing well. It's a really good story.
That's why I love coming to listen to the discussion, just to hear kind of the changes that have been made. Like, and I am so thankful every day that he's here, because for quite a few years, he was like, I don't know what the data says now, but back then he was one of the oldest ones that had survived hypoplastic left heart syndrome. So.
Yeah, I mean, 1991, I was, what the hell was I doing? Well, I was still in my residency, but they, it was still a crapshoot of whether you should do a Norwood, let the kid go home and die, or there were a few places that were doing, just a few, like, I mean, 1 or 2 places in North America that were doing primary heart transplants with kids with hypoplastic left heart syndrome. And the whole sensitization thing for those kids is like a big deal. For the people that don't know what that means you have so much foreign stuff in your body after you've had a Norwood and a Glenn, or any kind of foreign tissue, like even Jen, your kid has a homograft, that's foreign tissue. Or if they've had blood transfusions, they get antibodies that develop, and those antibodies make it harder to find a good match. And so when I was actually in the States, and one of the programs I was at, we had this desensitization protocol where we would, like, kids would come from all over the United States to us, and then we would give them all these meds for a few months and desensitize them and try to reduce their antibody loads, so increase the likelihood of them getting a donor heart. But sounds like, he sort of got the lottery pick, especially if it was like 2020, 2021 COVID years. Hearts were a little bit harder to come by back then.
Well, and that's where, it was right in COVID, because he got put on the list in March, and the call was in October. And like, I'm still baffled to this day how, you know, he got a match per se, and that like he had 2 rejections like right after transplant while we were still in Edmonton. But since then, and I'm knock on wood every time I say it, and it's like, I'm baffled how he can be doing as well as he is if he was like that sensitized, you know. So it amazes
yeah,
me.
I mean, if you got a desensitized heart, like a heart that was a good match for him, then he's like, it's in the wash. All that sensitization stuff doesn't come into effect afterwards. So I don't know the details, obviously.
Yeah.
And the COVID thing is weird too, because, you know, again, I don't know the details. I don't know where his heart came from, but if his heart was local, like if it came from Edmonton or Alberta or something, he might have got it because it was local and nobody was traveling back then. Like nobody was jumping on an airplane to go get a heart. So we would just say no. It was, I mean, in my circumstance, it actually didn't come up because there weren't that many donors, but we talked about it. Like if I had to go to the States or something to go get a heart, like the answer would have been no. Like,
Yeah.
I'm just not going to do that. So
his came from BC.
Oh, it did.
Yep.
Well, anyway, I'm glad it all worked out.
I know. Yep.
Let's see, iPhone 2, you don't have a name, but if you want to either ask a question out loud or type one in the chat or tell your story, I'm happy to have you do any of the above. Otherwise, I will, and you can do it anytime. I'll jump to some of the questions. So the first question is from Alex in the chat regarding Liam's pulmonary vein stenosis. What do you know about drugs that can help or slow the growth of the disease? Gleevec, Pectosol, anything else? So for those of you that don't know, pulmonary vein stenosis, so the pulmonary veins are the veins that drain the blood back from the lungs to the heart. So after the blood's gotten oxygen in the lungs, then they get returned to the left upper chamber of the heart or the left atrium, or in a single ventricle, the atrium. And the pulmonary veins are the blood vessels that carry that blood. And in kids like Liam, they develop pulmonary vein stenosis. There's a whole bunch of different types of pulmonary vein stenosis, but it's one of the more problematic diseases because there's not a lot of great treatments for pulmonary vein stenosis. And it's a bit of a crapshoot. Some kids have pulmonary vein stenosis and it gets really bad and things don't turn out so well. And some kids get it and it stagnates and they live with it forever. And some kids get it and it just is in one area and the rest of the veins are fine. So it's a bit of a black box, which is the reason you'll find all these therapies when you go looking for it. Because usually when there's a whole bunch of different ways to treat any disorder, it means that nobody's come up with the way to treat it. There's no Tylenol out there that will reduce your fever. So there's 20,000 drugs you can take to maybe try to help. So Gleevec is actually an anti-cancer drug. It's used for some blood cancers. And so that's how it works, from preventing the proliferation of whatever cells are multiplying around the pulmonary veins that cause scar tissue or stenosis or narrowing of those veins. It's been used with some success, but it's been more used, those types of drugs have been more used in concert with stents inside the pulmonary veins. So usually stents inside the pulmonary veins, so when you put a little metal stent inside the pulmonary vein to stretch it open, they typically haven't been great ideas because the stents themselves scar down and they get tissue buildup inside of them. So people have tried, there was a trial in Boston a number of years ago, they tried these anti-cancer, anti-proliferative drugs to prevent that buildup of tissue to make the stents last longer. I mean, the results were okay. There was certainly no miracle cure in any of those. So I don't think it's standard therapy. Pectosol, I don't really know anything about Pectosol other than I thought it was one of those makes you live longer drugs. So I didn't know it had anything to do with heart disease. So I'm a bit ignorant on that. And anything else, not really from a drug perspective. Right now, again, it's either interventional stuff in the cath lab, surgery, or wait it out and see what happens with the pulmonary veins. And like I said, there's so many different types of pulmonary vein stenosis. We had a kid, or not a kid, mom and a dad on last time when you guys were away. They were talking about pulmonary vein stenosis in their child, but the kid didn't have heart disease. It was just a prem. And that's one of the more common types of pulmonary vein stenosis in kids without heart disease that are just premature kids. And they develop de novo pulmonary vein stenosis. They're typically very premature, but I've seen that go so many different ways. Like I've seen premature kids with pulmonary vein stenosis get it, and then it turns really bad really quick and they die. And then I gave an example to this mother and father of a kid that I operated on that had complex heart disease, but was also a prem and developed pulmonary vein stenosis. And everybody thought he was going to be one of these ones that rapidly progressed and died. And he had one pulmonary vein that was really bad and got stented. And that was, I don't know, 14 years ago. And he still has the same stent. And the other pulmonary veins, one of them is toast and the other two are fine, but the kid's totally fine. So he's outlived everybody's prediction. Like he's totally fine. And his pulmonary vein stenosis is probably quiescent at this point. It's probably just halted progressing. So who knows how long he'll be good, but he'll probably be good for a long time. So it's unfortunately one of those things where there's no magic medical cure. Okay, Colby. So Colby was born with a type of single ventricle variant, and he got his Oh, right. Colby's dead. Alessio was born with a single ventricle variant, and he got his cath last week, I guess, his pre-Fontan cath.
Yeah, we got information for you. They haven't sent it out to you. We're gonna request it and get it, but they've told us more or less the results, and it's very favorable. We definitely have some questions for you today, but we can go through the ones we wrote down first.
Yeah. So the question is, the first question was, does the heart need to be stopped during the Fontan? Is it better, safer to be on the bypass machine? So that's a good question. So this is one thing that parents don't often understand, this whole bypass, stopping the heart business. It gets a bit confusing. So anytime you go for open heart surgery, that means you're going on the bypass machine. That's what open heart surgery is. It's when you get put on the bypass machine. It has nothing to do with actually opening your heart. It means you're using the heart-lung bypass machine. So there are certain operations that are called closed operations that don't need the bypass machine. They're like shunts, a pulmonary artery band, things like that, where you don't need to put somebody on the heart-lung bypass machine. Certain Glenn operations, depending on the anatomy, you can do the Glenn operation without the bypass machine. I used to do that a lot, but a lot of surgeons don't because it's easier to use the bypass machine. But I kind of thought the Glenn was one of those ones where it's, I learned how to do it without the bypass machine, and it led to a lot less problems if you didn't use the bypass, or less problems, I should say, if you didn't use the bypass machine. So I don't remember if I did Alessio.
I think you told us that you didn't use it on him.
Yeah, probably I didn't. If I put a pulmonary artery band on, it means that I probably didn't use it. Now, the Fontan's a different kettle of fish. Can you do a Fontan without a bypass machine? In theory, yes, and people have written about it, but it's much more difficult, and I think it's much less safe. Okay. I think it's actually safer to use the bypass machine for the Fontan. So I always used it. Now, as far as stopping the heart, though, just because you use the bypass machine doesn't mean you have to stop the heart. So there's a lot of operations we do where we use the bypass machine but don't stop the heart. Like if somebody has a conduit, like Jen's son has a conduit between the right ventricle and the pulmonary arteries, if and when that conduit needs to be replaced, you have to go on the bypass machine because you're taking apart the heart, but you don't have to stop the heart to replace the conduit. You can let the heart beat the whole time. But it doesn't have a lot of blood in it because most of the blood's in the bypass machine. So that's what makes it doable. Now, a lot of that stopping the heart, not stopping the heart business depends on whether there's any connections between the left and the right sides of the heart. Because if there are connections, then, and you're going to open up the heart, you have to stop it. Otherwise, you'll get air in the heart, and that air in the heart can go to the left side, which can go to the brain and cause a stroke, or to other organs and cause other problems. Now, most Fontans, like I would say the vast overwhelming majority of the current version of the Fontan, which is called the extracardiac Fontan, you do not have to stop the heart for. But if you have to do something on the inside of the heart, then you have to stop the heart. Now, in Alessio's case, the only thing that you might have to do is if you take off the pulmonary band, then you have to cut out the pulmonary valve. You can't just leave it there, otherwise it'll cause blood clots. And if you do that, you can actually do it without stopping the heart. You can do it by putting the heart in this weird rhythm, but even if you stop the heart, you only have to do it for a very short period of time. The way I did it is I put the heart in this weird rhythm, and so that there was no air possibility, and that only it took me like literally 90 seconds to cut out the pulmonary valve. But the whole question is whether or not you have to take off the band, and that really depends on how much blood is flowing across that band still. So it's going to be tighter than when I put it on because he's older and bigger. So he will have grown. The band will still have constricted that pulmonary artery and now constricts it even more. So sometimes at the time of Fontan, there's so little blood going across that band that you can ignore it. But if there's a significant amount of blood still going across the band, then you have to get rid of it. And then you have to cut out the valve and cut the pulmonary artery in two. And again, for that part of the operation, most surgeons would stop the heart for a short period of time. So there's no benefits to leaving the band on if there's a lot of blood going through it. In fact, there's downsides to it. But if there's not that much blood going through it, then you can ignore it. And that information will be present based on the cath results.
Okay, excellent.
So when you send me all that stuff, I'll be able to like definitively tell you. Well, I can't definitively tell you what anybody else is going to do. I can definitively tell you what I would do.
Okay. We have a couple more questions if that's okay. Just because
Yeah,
I've been
of course.
mentioning the DKS and so my wife's here, she kind of talked to them today because they actually phoned today. She has more information than me about what they're reading.
Yeah, so like I talked to Dr. John today, and she explained that because right now my son's like the aorta, I think it's like wide open. So in fact, he doesn't really need a DTS right now, but like it will be beneficial to get it done right now because after the plan, they are looking at this in the future, and if there is
Yeah, that's a difficult question. So a DKS, for the rest of the audience, is where you sew the pulmonary artery to the aorta. And what that does is it bypasses any obstruction underneath the valve. But that's a completely different operation than a Fontan. That does involve stopping the heart for a considerable amount of time. It involves cutting the aorta. It's a much bigger operation. So a much bigger operation than the Fontan. So there has to be compelling evidence that he would benefit from it to actually do it, because it really changes things. Now, having said that, if there is compelling evidence, then the cardiologist is right. Now's the best time to do it. It's much better to do it now than to come back at some later point in time and do it. But you have to really, like, I would want to see the evidence.
Mm-hmm.
Says,
that's my big question.
Yeah.
Because if they're saying that it's wide open, his pressures are super low and everything's fine, I'm a physiotherapist and I want to like look data is indicating that that's what should be done.
Yeah, no, I mean, I think you're valid in those questions. So again, once I see the pictures, I can help you with that a little bit more.
Excellent. We really appreciate that.
Yeah, no problem. So there was another question on here, and I'll answer it even though the person I don't think is on. No, it was about the Glen in general. And so,
Cierra, por favor.
yeah, it was what is a Glen procedure essentially? And so just again, for people that most people probably already know this, but a Glen procedure is either the first or second stage of the whole single ventricle thing. Some kids need a first stage operation, meaning they need a shunt, a band, a Norwood. That's the first stage. Some kids get by without that if they have reasonable blood flow to their lungs, and then the Glen becomes stage number 1, and then Fontan is number 2, and there is no number 3 because there was no number 1. So, but what a Glen is the first step in diverting blood from the body directly to the lungs. So in kids with single ventricles, they only have 1 pumping chamber instead of 2. So in you and me, we have a right ventricle that pumps blood to the lungs and a left ventricle that pumps blood to the body. But in single ventricle kids, they only have 1 ventricle. So of course that has to pump blood to the body. And so you have to get blood to the lungs through a different mechanism. And that mechanism is sewing the blood vessels that bring blood from the body back to the heart directly to the lung arteries, that is bypassing the heart. So there's nothing that pumps blood to the lungs like it does in you and me. The blood just gets there. And the way it gets there is through the Glen, step 1, and the Fontan, step 2. And the Glen is from the upper part of the body. So the blood vessel that drains all the blood from the head, neck, shoulders, everything above here. And you disconnect that from the heart and sew it into the lung arteries. And the Fontan is all the blood from the lower part of the body. And so you disconnect the blood that drains blood from all the lower part of the body, the legs, the belly, the liver, all that stuff. And you disconnect it from the heart. And with a tube, you connect it to the lung arteries, which are about here. The upper one you can sew directly because it's right next to it. The lower one, you need a tube because of the gap. So you put a tube in between the inferior vena cava, or the IVC, and the pulmonary arteries. And now we use a tube, and that's why it's called the extracardiac Fontan, because you do it all outside of the heart. You use an artificial tube to connect the IVC to the lung artery. So that's what that is. And the second part of that person's question was how to keep kids thriving despite the heart condition. And that's a question we've talked about a lot in these sessions, and it's to just treat them like normal kids. And a lot of them are going to have, bumps along the road, but the whole point in doing all of this is to have them live as normal a life as possible. So yeah, you have to behave in terms of restrictions if you're given any, but otherwise, hopefully these operations will help your kids just be normal. The next question was from Kaye. Long-term complications of a 1.5 ventricle, how to manage them in life expectancy. So the 1.5 ventricle is like halfway between this whole single ventricle thing where you have only 1 ventricle that pumps blood to your body, and the normal situation where there's 2 ventricles, one that pumps blood to the lungs and one that pumps blood to the body. So at 1.5, that means that 1 ventricle, typically the left, is good. It's normal, fine. And the right ventricle is borderline. So the right ventricle is not good enough to do all the work to pump all the blood to the lungs, but it's decent. So you don't really want to just get rid of it or ignore it. So in those circumstances, you allow the right ventricle to do some of the work, and you allow an ASD to remain open, or a hole between the 2 upper chambers of the heart, so that some blood can get from right to left and not have to go to the right ventricle and not have to get pumped to the lungs through the right ventricle. So that's why we call it a 1.5 ventricle situation. The long-term results of that scenario are certainly as good as the 1 ventricle situation, and probably better than the 1 ventricle situation. Nobody can really tell you what long-term life expectancy is, or super long-term results is, because all of this stuff is relatively new. Like this whole single ventricle, 1.5 ventricle, all of this stuff is like, it started really with any earnesty, sort of in the 1970s, 1980s. And for conditions other than hypoplastic left heart syndrome, really surgeons started to get good at it in the 1980s. So we're still only, 40 or 50 years into this. So nobody can tell you, and there are kids with certain single ventricles that are in their 50s and 60s now, but nobody can tell you what the long-term life expectancy is. In terms of how to manage a 1.5 ventricle kid, you don't really manage it any differently. They do have a connection in between the left and the right sides of their heart. So anytime you have a connection between the left and the right sides of their heart, you're always more prone to certain problems like stroke, because blood clots that occur on the right side of the heart can cross over and get into the left side of the circulation. So that does matter when it comes to things like pregnancy, for example, for females, because pregnancy is a clot-inducing condition, and if you have a connection in between the left and the right sides of your heart, not to mention that you have a heart that isn't potentially able to tolerate the stress of pregnancy as well as a normally functioning, normally circulating heart, you have to worry about that kind of stuff. But we have enough adults with complex congenital heart disease around now that a lot of the adult congenital cardiologists are well versed in all of this stuff, and there are protocols in the adult world for a lot of these things. So it won't be the first time, I'll put it that way, that they've encountered situations like this. I hope that answers the question. Let me think. There was another question here about COVID and heart disease in kids. The question was, again, I don't think the person's on, have COVID-19 infections resulted in increased heart disease in children? So that's a complicated answer, because in kids specifically, the answer is probably no, but COVID in and of itself is a clot-inducing disorder, especially when acquired multiple times. Like that's pretty solidified science at this point. So, there's a significantly increased incidence of death in the age group of teenagehood to young adulthood, like sort of the 15 to 50-year-old age group. The incidence of sudden death has gone way up in the last 4 years. Now, a lot of the anti-vax community will like to tell you that's because of the vaccine. That's just not true. The incidence is much higher in the unvaccinated population, and that's because of clot formation. And it's usually with repeat COVID infections that propensity becomes even more. So you do have to worry about it. I don't think, though, you have to worry about it any more than the general population has to worry about it. We were really worried at the beginning of COVID if kids with congenital heart disease were going to be more susceptible to the after effects of COVID. I don't think we've proven that to be true, but we have proven in general, even though public health might not want to admit this, is that repeat COVID infections do take a toll on the body. So if you know your kids had 4 or 5 COVID infections, that's something that you do have to worry about. I think I've gone through the list that's here with this small group, but if anybody has questions about the questions or any other questions or wants to chat about the weather or
I have a
seaplane
question.
hitting the boat, yeah.
Not
Go
about
for
the
it.
weather. I'm just curious with again with Liam's PVS, how would you see if it's like, what would determine him it getting worse? Like what kind of symptoms should I be looking for? Or is
They
it
get bluer?
catheter? Okay.
No, well, so some kids hide their symptoms incredibly well. So then it's based on imaging studies, either echo or cath, or a CT scan. I think CT scan is probably the most effective test when it comes to repeat evaluation. I mean, you can ask the cardiologist, but I think that CT scan is probably the most effective test. But as far as symptoms go, it's bluer, shortness of breath, exercise intolerance. That's it.
Is coughing something?
Yeah, coughing.
Like a dry cough?
Coughing is one of those things. Like there's a zillion things that can cause coughing, right? So it doesn't mean because he's coughing doesn't mean his pulmonary vein stenosis is worse, but coughing can be a representation of pulmonary edema, which is fluid in the lungs, which is one of the things that happens with pulmonary vein stenosis.
Okay, so like a wet cough.
Well, it doesn't have to be wet, but it could be, yeah.
So I'm asking is because Liam's starting to have a wet cough. So is that something that like I should be digging into further?
Well, I think it depends. I mean, if it's something that's persistent and worsening, yes. If it's
okay.
I picked up a bug in Florida and it's going to get better in a week, then no, obviously.
No, he's had it for a few weeks now, and there's no other cold symptoms or anything. Like it's been over a month that he's had this.
It's new.
Well, I don't know. Like, I feel like he's always had a cough, but I've noticed it's like extremely like it's wet, and he has no other cold symptoms. Like it's not sick or anything, so that's why I'm confused.
And is it all the time, or just with exertion, or?
It's not like, all the time.
Does he cough at night when he's sleeping?
Sometimes, yeah, he'll go through a fit and then he'll be fine.
Yeah. Well, I mean, I think if it persists, it doesn't hurt to get it checked out, at least to start with an echo and see, because you can sometimes just tell from the pressures inside the heart, as a surrogate measure, if they're higher, is it the pulmonary vein stenosis or whatever. So it doesn't hurt to get it checked out.
Okay. Sounds good. Thanks.
I have a question.
Yeah, Jen, go for it.
What do you know about the self-expanding pulmonary valve implant? The Edmonton recently did a surgery with that, which seems like a kind of a breaking news sort of story. I was curious about it.
Yeah, it's not that breaking. They're old. I mean, the technology has existed for probably a couple of decades, but the iterations of the technology are getting better and better, right? So these pulmonary valves, it used to be that all pulmonary valves needed an operation to put them in, and what you're talking about is a percutaneous pulmonary valve. So they put the pulmonary valve in the cath lab, basically, so through the leg, and it starts off as this tiny little thing, and then they blow it up and it expands, and now, or you go in there and it self-expands inside the pulmonary artery, whatever. Like it starts off small and it gets bigger and it fills the space. When I say the technology has evolved, the criteria for implantation used to be very strict. You used to have X, Y, Z, A, B, C in order to be a candidate. And then, A, B, C went away and it was just X, Y, Z. And then, Y went away and B went away. And so they've expanded the criteria. So honestly, I don't know in the last year since I've been out of it, like what if the criteria have expanded even more. But it used to be based on the size, the landing area. It couldn't be too big. It couldn't be too small. If it was too big, there was nowhere for it to expand. And it would be free floating. If it was too small, then it didn't work out. When it first started, you used to have like a homograft in place, like Thaddeus has, to be able to put the pulmonary valve in through an existing homograft or through an existing artificial valve. It couldn't be native tissue. Anyway, as manufacturers figured out they could make money off this stuff, the number of different companies making these types of pulmonary valves has grown immensely. Like there used to be just one type of percutaneous pulmonary valve, and now there's 4 or 5 or 6 or 7 or God knows how many types of these things. It's just like heart valves, right? There's not just one company that makes them. Everybody's company has the new best thing. So I'm not sure it's breaking technology. It's probably evolved technology.
Yeah.
But Thaddeus isn't ready for anything like that yet, is he?
Not that I know of. Like, everything keeps coming back normal, but he's always hid everything from us, like, right? So part of me is also looking at the fact that he just turned 13 and he's in the big jumping in size. He's growing like
Yeah.
crazy.
Yeah.
And he had that done when he was 5, and that valve has not changed size since he was 5. And also looking at
Yeah,
kind of where we're at in transferring into adult care in the next few years and pondering, like,
Do you remember
when
what
was
size it was?
No, but I know that you could
Oh.
do an artificial valve because the smallest one you could find was still too big.
Okay, well, anyway, he had a homograph because he had a Ross. So whatever size it was will be in the op note because I always put it in there. So I tried to use the most reasonable size. That doesn't necessarily mean the biggest size because too big actually can wear out faster because it can get pressed on by the breastbone. But typically those valves tend to last a fair bit of time. So, but you're right. The thing that hurts the most is the growth spurt years. And it's not just because of the actual growth, it's because of calcium metabolism in teenagers is awful. And so they tend to calcify those valves quicker once they hit those years. And so, but, like every kid is so different. I wish if I understood that stuff, I'd have won a Nobel Prize somewhere along the line. But some kids, those valves can last like forever and a day. I mean, I've replaced those valves 15 years later in kids that had them put in as infants, not at all understanding how they lasted until they were late teenagers. And then sometimes I put them in a 5-year-old, and by the time they were 8 or 9, you were reoperating on them again. So it's a bit of a crapshoot.
Yeah, I think, like, just trying to figure out as a parent, advocating timing for that causes me to lose some sleep some days. Because again, he's been so good at masking when his heart is not doing well. That kind of timing that out, like, he is on definitely every like 3 months, 3 to 6 months for his checkups now. She's up to how often she sees him to kind of keep an eye on it, knowing that he's in a particular age bracket where that could become more important very quickly. But yeah, just kind of like looking at what are his best options and for the next surgery, because we don't want it worse than the last one.
Yeah, well, I mean, hopefully he's a candidate for a percutaneous valve. I mean,
Yeah,
have to sort of wait and see. Speaking of valves, how's Liam doing? You're muted.
Me?
No, the other Liam.
Oh.
Liam the Heart Warrior. That Liam. She's muted.
Levi?
iPhone 2. Yeah. Are things clot free? Oh, still muted. I don't think she can figure out the technology. But anyway, does anybody else have any other questions?
I have a question,
All right,
Dr. Gandhi.
Yeah, go for it.
Hi, sorry that we are late. I've noticed really that, like, with my daughter, and she's like right now at the Glen stage and repair, so she doesn't really have a pulmonary valve. Like, we went through like these like years, probably like between she was like 7 and 9, where her hands were a little bit warmer, even in winter, because her hands have always been like kind of on the coldish side in a warm day. But like lately, probably in the last like 6 months, what I've noticed is that her hands are becoming cold as well, like her fingers, but she doesn't have any symptom other than kind of like shortness of breath or exertion, no headaches, nothing at all. So
that can be due to so many things. It's really hard to tell, but it's hard to attribute extremity warmth to the pulmonary valve. Okay. It can be due to lots of other circulatory issues, but not the pulmonary valve.
No, okay. Yeah, I just wondering if it's kind of a symptom really of like her needing really another surgery like fairly soon, because like she's been really like so warm, kind of like normal, not like extremely warm, but just normal temperature, when she's always been kind of on the coldish like side, kind of cold hands. But yeah, thank you.
Yeah, you're welcome. All right, Tony, I think we can wrap it up.
Sounds good. Yeah, thanks everyone for jumping in and asking your questions. As I mentioned at the beginning, we have the registration page that everybody uses to sign up for. Please feel free to share that with any friends, anybody that might find value from these sessions. The next one will be the second Tuesday of July. July 9th will be the next one at 6 p.m. And yeah, feel free to share it with all your friends and stuff.